Hello everyone. Hi, welcome to the NEET-PG 2022 recall session. This is Dr. Shivangi Shukla and we'll discuss the questions from ophthalmology here on this channel of ADrPlexus. I hope all of you did well. There were a lot of questions which we had discussed during the INI-CET recall also. And most of the questions in our usual sessions, quite a few sessions that I have taken in the past 1 or 1.5 months, most of the questions were from the high yield topics which we had discussed. So I hope apart from that, there were a few questions which were borderline on the controversial side. So that we can leave it out also because it is mostly recall based. So we are not 100% sure about the authenticity of the options, because it is a lot of it is hearsay and a lot of confusion regarding the options. All right, so any which way, mostly from the feedback that I have been getting from all those that have interacted, it has been a good feel good paper, especially from the point of view of ophthalmology. So congratulations. But at the same time, we can see there has been a lot of focus and intensive focus on clinical approach, clinical based questions and picture based questions. Okay, so just rote learning does not yield results now. It is high time we focused our energies on building our aptitudes, building our clinical skills. Okay, and clinical skills include not just learning, not just going in a straight track, rather knowing when to diversify. That is, you have to make associations from all the 19 subjects. We'll come across, I think, a couple of questions which have involved biochemistry, which have involved medicine, which have involved pediatrics, inborn errors of metabolism, and ophthalmology together, integrated approach. Okay, so it is very important for you guys to focus your energies on developing clinical skills. Okay, that is a very interesting way of reading also, because just rote learning, reading something again and again is going to be very drab. All right, so enough said, let's begin. Okay, you guys would get bored looking hearing to my didactic lectures. Let us begin. All right, okay. So here is the first question that we are going to discuss. A known case of rheumatoid arthritis. Now this is a clinching keyword here. A known case of rheumatoid arthritis comes with the following presentation. What is the presentation? This one. Okay, most of the people have said that the image that was there is somewhat like, okay, this is one of the Google images that I have taken. So most of the people are saying this is this is mostly what was the image was. Okay, so this is what information do you have? You don't know whether he's a male or a female. That has not been given as far as I know. And you just know that the person has rheumatoid arthritis and the person's eye looks like this. Okay, now you have to make the diagnosis. This is a clinical question. This involves your knowledge of medicine as well. All right, now rheumatoid arthritis is what type of a disease? Rheumatoid arthritis is an inflammatory condition that usually involves the joints. This is the basic knowledge that we know about rheumatoid arthritis. An inflammatory condition involving the joints usually involves females. All right, now this inflammation is not just limited to joints, rather it affects quite a lot of areas as well. Okay, so we know that rheumatoid arthritis involves not just the joints, but one major organ that it involves is the eye. And how does rheumatoid arthritis involve the eye? What is the condition that rheumatoid arthritis causes in the eye? One very important condition, that is, it causes, just a second, rheumatoid arthritis causes non-necrotizing necrotizing without inflammation. Okay, necrotizing without inflammation or non-inflammatory scleritis, isn't it? And that scleritis is what is called what? That scleritis is called, yeah. So it causes non-necrotizing with inflammation What is the condition that it causes? Scleritis. Scleritis means inflammation of the sclera. Itis means sclera. So scleritis is inflammation of the sclera. What is the sclera? It is the white coat. Now can you see this? These vessels, they are present in the conjunctiva, and the red vessels, the extremely red vessels are present in the conjunctiva. The vessels below them, they are present in the episclera, okay? And then just below the episclera is present the sclera, that is the whitish coat. Okay, understood. Now inflammation, this inflammation, can you see this inflammation is involving the white coat of the eye, and that white coat of the eye is what? It is the sclera. So this is, and why is this black? Why is it appearing black? Do you know why it is appearing black? Because it is appearing black because the choroid just below the sclera is shining through. Okay, so please mind it. This black thing is not because the sclera is necrosed. No, it is appearing black because the choroid just below the sclera is shining through. And why is it happening? Because the sclera has become inflamed. Okay. So the correct answer, this is known as, this type of scleritis is known as scleromalacia perforans. Now, what did I tell you in all my classes? What did I tell you? For any difficult sounding word, you have to break it down to the Latin roots. Now, sclero, what is sclero? Sclero means the fibrous coat, that is sclera. Malacia, what is malacia? Osteomalacia. Malacia means weakness. Okay, it means weakness. Sclero is sclera. Perforans, as the name sounds, perforans is something that is perforated. Okay, or that is about to be perforated. That is, the perforation is imminent. So scleromalacia perforans, the sclera, because of the inflammation, has become so weak that it is about to be perforated. That is why the choroid that is present beneath the sclera is shining through. Okay, so the clinching diagnosis, the clinching keyword here is what? It is rheumatoid arthritis. Okay, because had rheumatoid arthritis not been written here, this image can very easily be confused per se with ciliary staphyloma, the option B. Even we could get confused with it. If any person is coming to the OPD with such a picture, then the first diagnosis that can come to the mind is that of staphyloma only. Okay, but because rheumatoid arthritis has been mentioned, the examiner wants to draw your attention towards this. Okay, so I'm telling you, pay attention to each and every term, to each and every clue that is given in the question, because it is given for some purpose. The examiner has something in mind for which he has included that. Okay, so rheumatoid arthritis is not just mentioned as a past history. No, it has some significance, and that significance is to bring your attention with towards the association of rheumatoid arthritis with scleritis, and that condition is known as scleromalacia perforans. All right. Ciliary staphyloma. What is a staphyloma? Staphyloma is bulging, protrusion of the sclera, the outer fibrous coat of the eye, which can be the sclera also or the cornea. Okay, the outer coat of the eye is what? The sclera and the cornea. So the bulging or the protrusion of the outpouching of the outer coat of the eye and ectasia of the uveal tissue inside it is known as staphyloma. Okay, so it consists of two definitions, two points in the definition. One is bulging or outpouching of the outer coat of the eye, and ectasia or incarceration of the uveal tissue. Okay, so staphyloma is what? The outer coat will bulge like this, and the coat just beneath it, that is the uveal tissue, the choroid, the iris, the ciliary body, they are going to get trapped inside that. Okay, understood? Similar to this, can you see this? If this also appears to be a staphyloma, right? This, it seems that the sclera here has weakened, it has bulged out, and the choroid tissue has been trapped inside this bulge, just like a hernia, isn't it? So the staphyloma is similar to a hernia, all right, inside the eye. Got it? What malignant melanoma, everyone knows the tissues containing melanin, it affects, this is the type of malignant tumor that affects the melanin cells, that is mostly the choroidal cells. Okay, now what is coloboma? Coloboma, in the INI-CET top session also we had discussed. Coloboma means hole, a deficiency. So coloboma involves the iris, it also involves the fundus. Fundus means it involves the choroid, it involves the retina, the posterior pole. Okay, usually it appears in conjunction, known as the iridofundal coloboma. Coloboma means a deficiency. Usually what happens is, see, this is the iris tissue, and this one is the pupil. Okay, so what happens is, the iris usually forms like this. Okay, and then this is going to get, these two areas are going to merge together like this. Okay, to form a circular pupil. Now, if this merging does not take place, then what happens is, the pupil remains like this. And there appears to be a hole, there appears to be a deficiency in this part of the iris, because both of them have failed to merge together. So it is an embryonic defect. Understood? This is what is coloboma. So this area, this merging takes place in the infero-nasal aspect. So the most common, more than 90% of the iris colobomas are infero-nasal in location. Okay, so let us move on to the next question. Another image-based question. What does the following slit lamp image depict? Okay, now let us first look at the image. Wait. Now, most of the people, barring a few of the students who have interacted with, most of the people are of the view that the image that was given was somewhat like this, dandruff-like material present in the anterior chamber and on the anterior capsule of the lens. Okay, this is what we can see. Now, this is a slit lamp. The light is shining through on the anterior chamber, and the anterior capsule of the lens has also been lit, and you can see everything, this flaky dandruff-like material present on the anterior capsule. It is present near the pupillary margin also. Can you see this? This dandruff-like material is present everywhere in the anterior chamber. Okay, so what is this? Out of these options, can you tell me what it can be? Some people are of the opinion it is uveitis. Glucoma, I don't think any of you would have marked glucoma if you have a good understanding of ophthalmology. Glucoma is something that involves what? It involves the cornea, guys. This is what we have discussed extensively, isn't it? Now, this is the cornea. This is the side view, the sagittal section, if you say. Glucoma is one of the 3 corneal opacities, gradings of the corneal opacities. Now, it is the densest of all the corneal opacities. Okay, the least dense is the nebular corneal opacity. Okay, then intermediate you have the macular corneal opacity, and the most dense corneal opacity is the leucoma. Okay, but which of these is visually most impeding or most annoying? Visually most annoying of these 3 is the nebular corneal opacity, because it causes diffraction of light. The light that falls, see, this is the nebular corneal opacity. Okay, when light falls on this, it gets diffracted everywhere like this. Okay, and the image appears very blurred. Okay, so the whole of the object appears blurred. Whereas this is the macular corneal opacity. Now, nebular opacity is denoted by dots like this. Macular opacity is denoted by dashes like this. And leukomatous corneal opacity is denoted by hashtag. Okay. So macular, it will allow some light to pass and little bit will get diffracted and some will not pass through. Leukomatous, what will leukomatous do is it will not allow any light to pass through it. Okay. So what happens is only some part of the image is obstructed through leukomatous opacity, whereas the rest of the object, the rest of the light will safely pass through. Whereas in nebular opacity, what happens is the whole of the object becomes such a blur because of diffraction. So please understand the densest corneal opacity is leukomatous, but the most visually annoying or debilitating one is nebular. That is the thinnest or the least dense. Okay, the sparsest. Understood? Now, what is uveitis? Uveitis is an inflammation of the uveal coat that involves choroid, iris, ciliary body. Uveitis, typically, the sun classification deals with aqueous cells and aqueous flare. Okay, cells and flare. Now, in this image, these are not cells or flare. Okay, aqueous cells and flare, they appear to be, the cells appear to be swimming. Okay, the cells appear to be swimming in the aqueous, and flare is something like the Tyndall effect. You must have heard of the Tyndall effect. What happens is that is due to scattering of light. What happens once you enter a dark room? The room, suppose you enter a room that is not lit by any light, okay, but it has some hole through which sunlight is coming in. Now, in that beam of sunlight, you can observe dust particles dancing about, isn't it? So that is Tyndall effect, and that is what is the aqueous flare that you see in uveitis. So this image is not that of uveitis. All right. So both of these we have eliminated. Next is pseudo exfoliation syndrome, and that is what is this thing, pseudo exfoliation syndrome. This is what it is. It is deposition of dandruff like flaky material, and it is due to a congenital fibrillin defect. Okay, now fibrillin is what? It is present in the extracellular matrix. Okay, so extracellular matrix is what? Connective tissue. It is present everywhere. So this fibrillin defect, fibrillopathy, this occurs, this leads to deposition of dandruff-like flaky material inside the anterior chamber of the eye. And how is it very dangerous for the eye? Because this flaky material will not just occlude the anterior chamber, rather, where is it going to go? The dangerous area. See, again, we look at the sagittal section. This is the cornea, this is the iris, and this is the lens. Okay, anterior capsule. Now, this is the anterior chamber. The flaky material will be deposited all over here. And this is where we don't want it to go. Where? In the angle. It is also going to go and block the angles. Once it has blocked the angles here, and from the angles, it is also going to go to the trabecular meshwork. It is going to block the trabecular meshwork also, leading to what? It is going to lead to glaucoma. What type of glaucoma? It is, this glaucoma is secondary to some disease. So, secondary glaucoma. Secondary to there's some other disease that is going to lead to this glaucoma. So, secondary glaucoma. Got it? So, see, in ophthalmology, most of the conditions are going to end up in glaucoma. The end eye stage is going to end up in glaucoma. And how and what type of glaucoma it is leading to, that is what you have to decide. Okay. So this pseudo exfoliation glaucoma also, if left untreated, is going to lead to glaucoma, secondary glaucoma. Okay. Now ocular trauma. This is not ocular trauma, because ocular trauma, if it had been, it would be this kind of an image. A few of the people are saying that it was this image also, which is called what? This is a type of cataract. What type of cataract is it? It is the rosette cataract. Rosette means Rose petals. These appear to be petals of a rose like this. Now, due to blunt trauma, what happens is due to coup contre coup lesions. Have you heard of coup contre coup lesions in forensic? Coup contre coup lesions. What happens is coup means due to the trauma, uh, the direct trauma, the force of the blunt trauma is coup. Okay, and all the, so this is the eye, this is the lens, and this is the posterior coat of the eye. Okay, now this is the coup force. The direct trauma is leading to the coup injury, and the eyeball is then going to recoil. Okay, because of through Newton's third law, the eyeball is going to recoil. So this recoil force is going to lead to the contre coup injury. So this coup contre coup injury is what leads to the formation of rosette cataract in the lens after blunt trauma. Now, hearing of blunt trauma, you should also, one more term should come to your mind is that of Berlin's edema. What is Berlin's edema? Berlin's edema is the temporary cherry red spot present in the retina due to blunt trauma. Okay, that is Berlin's edema, or it is also known as commotio retinae. So, coup contre coup commotio, commotio retinae. How will you remember this? Commotio means commotion. Commotion means there's a lot of chaos, commotion. How is this commotion happening? Because of this coup contre coup. This something has beaten your eye and the eye is recoiling back. So there's a lot of commotion inside the eye. And this commotion is going to affect the retina. So the poor retina is going to suffer from commotion. That is commotio retinae. So commotio retinae occurs after trauma. Okay, got it? Okay, so if this was the image, then it is going to be ocular trauma, rosette cataract. But most of the people are saying that this was the image, so it is going to be pseudo exfoliation syndrome. All right, got it? Next question. The following lesion is seen in the deficiency of, again a picture based question. This one was an easy one. We have discussed this also. What is this? Soap bubble like deposit, soapy deposit. Can you see? It is this soapy deposit is, it is present near at the temporal side. It is present on the temporal side near the limbus. Usually, what shape is this? It is a triangular shaped structure with the base of the triangle near the limbus. Okay, this is what we read. So if you can see, this is the base of the triangle near the limbus. And this is the soap bubble like, this is the soapy deposit. What is this? These are Bitot spots. What are these? Bitot spots. Okay, due to the deficiency of, no points for guessing, extremely easy, vitamin A. Bitot spots occur in xerophthalmia. Xerophthalmia is what? Zero means zeros, zero fights, zerosis. What is zero? Zero is dry. So xerophthalmia is dry eye. So xerophthalmia is a spectrum involving a lot of stages which have been graded by WHO. Let us discuss. Okay. Now, the first one is XN. What is XN? The starting, the mildest. It is xerophthalmia N. These are the stages of xerophthalmia which we are discussing. Okay. Staged by WHO. Now, XN is night blindness. So, xerophthalmia is due to vitamin A deficiency. So, the mildest form is night blindness. That is delayed dark adaptation time. Okay. Then X1A. X1A is what? Conjunctival xerosis. Now, the dryness will start appearing from outside and then it will start progressing towards the more serious structures or the more important structures. Okay, so first it will affect the benign structure, that is conjunctiva. Then X1B is what our hero is here, Bitot spots, B for Bitot spots. Okay, X1B, Bitot spots. X2, what is X2? Corneal xerosis. Then X3A and X3B. Excuse me. X3A and X3B. This X here is all denoting xerophthalmia. X3A is corneal ulceration involving less than 1/3 of the cornea. Here the corneal ulceration or keratitis is going to involve more than 1/3 of the cornea. Now this staging is very important for pediatrics also. Okay, so in the final year pediatrics also we read this. It is very, very important. So always keep this in mind. Just right from your third year in your PSM, in ophthalmology, in pediatrics, all these three subjects are going to read this staging. It is very important that you learn it, you remember it. It is not very difficult. You just have to remember that it starts from outside to inside. It starts with conjunctiva and then it moves on to cornea, first drying, and then if drying is also not controlled, then it will lead to ulceration. When ulceration is not controlled, what will it lead to? Scarring. And ultimately, it is going to go to the deepest structure, that is, it is going to affect the fundus, xerophthalmic fundus. Got it? Just go through this. It is not difficult. Just remember the story that I have told you. Okay, it will start with very mild night blindness. Then it will start affecting structures from outside to the inside. Okay, understood this? So Bitot spots, soap bubble-like deposit occurring mostly in the temporal side near the limbus, with the base of the triangle present near the limbus. Okay, so this stage is what? This is X1B because Bitot spots are present. Okay, next question. A patient with a history of penetrating trauma diagnosed as sympathetic ophthalmitis in the emergence. Which of the following will be observed in the patient? A. Acute anterior uveitis. B. Chronic anterior uveitis. C. Pan-uveitis. Or D. Pars planitis. Okay. So here, this question is made easy by already giving us the diagnosis. The diagnosis is sympathetic ophthalmitis. Now, sympathetic ophthalmitis, the definition for this is bilateral. All these words you have to remember. Bilateral, diffuse, granulomatous, pan-uveitis. Bilateral, diffuse, granulomatous, pan-uveitis. Okay. Now, we'll see what each of these terms means. Okay. Now, acute anterior uveitis is correct. Why? Because penetrating trauma will, if there is penetrating trauma, means this penetrating trauma, this weapon or whatever has caused the trauma has breached the uveal tissue. It has breached the uveal tissue. Now, for sympathetic ophthalmitis, uveal tissue damage has to occur. Once uveal tissue damage or breach occurs, then the eye is prone to developing sympathetic ophthalmitis throughout the life. Okay, so if there comes a question that a person suffers penetrating trauma in the right eye, okay, the left eye appears normal for 1 year subsequent to the trauma on regular follow-up visits. Okay, so for how long is the left eye prone to develop sympathetic ophthalmitis? The correct answer is forever. Okay, even after years of penetrating trauma in one eye, the other eye is prone to develop sympathetic ophthalmitis. Okay, always remember this. So that person is always advised to be wary of symptoms. Now I'm going to tell you about those symptoms. What happens is, first of all, let us be clear about the terminology. The eye that has undergone the penetrating trauma, okay, the traumatized eye is called the exciting eye. Why the exciting eye? Because this eye has undergone the trauma and this is going to excite the uveal tissue of the other eye. So the other eye, the contralateral eye is going to be called the sympathizing eye. So are you clear with the terminology? That this is the terminology that we are going to discuss. Okay, exciting eye and the sympathizing eye. Now the first symptom of sympathetic ophthalmitis is loss of near vision or diminution of near vision or loss of accommodation. Why? Because who is the hero in accommodation? The ciliary body. The ciliary body expands and contracts and relaxes and pulls the zonules, and that is how the lens accommodates. Lens becomes thin and thick, thick. So loss of accommodation, loss of near vision is the first symptom of sympathetic ophthalmitis. So always tell the person who has one exciting eye after penetrating trauma to be mindful of the near vision in his in the contralateral eye, which could become the sympathizing eye. Okay, so always be mindful of the near vision. Okay, and the first sign is something that the doctor sees. Symptom is something that the patient tells. So the first sign of sympathetic ophthalmitis is lens flare. What is lens flare? Can you see this flare? These are the keratic precipitates, that is the cells, the inflammatory cells present on the back surface of the cornea, that is the endothelium of the cornea. Okay, present on the endothelium of the cornea. And can you see the light here is so milky, right? So this milkiness in the light is what is the lens flare. The light is not very sharp. Okay, if you see here, the light here is sharp. Here you can see the light here is so sharp. Here also the light is sharp, but here the light, the slit lamp light is so milky. So this milkiness in the light is what is known as the lens flare, and this is the first sign of sympathetic ophthalmitis. Now sympathetic ophthalmitis is going to affect the whole of the eye, and it is a granulomatous inflammation. That is, it is going to form granulomas. If you do the histologic examination or biopsy, you will find granulomas in the tissues. Okay, diffuse granulomas, not nodular, rather diffuse. The whole of the eye is going to get involved. Bilateral, both of the eyes can get involved. Panuveitis means all the coats of the eye are going to get involved. Panuveitis. Okay. Now, one important question that you should remember about sympathetic ophthalmitis is that sympathetic ophthalmia resembles which disease? Resembles the symptoms, signs and symptoms of which syndromic association? Can you tell me? It is very important. If you guys have had a thorough reading of this, you would know that it is similar to, its causation is not at all similar, but its phenotype or the signs and symptoms are similar to a disease known as Vogt-Koyanagi-Harada syndrome. This also is a bilateral granulomatous panuveitis. It affects the skin, the ears, the eyes. It is a congenital condition, okay, leading to deafness, leading to loss of pigmentation in the skin, and leading to panuveitis in the eyes. Okay, so a person that has panuveitis without any history of trauma, penetrating trauma, you need to look for other associations, maybe in the ear or in the skin, and to rule out Vogt-Koyanagi-Harada syndrome. Okay, now let us move on to the next question. Another image-based questions, no surprises here. The following surgery is done for which of the following conditions? A. Keratoconus, B. Keratoglobus, C. Vogue limbal girdle, or D. Cataract. Now, D. Cataract or corneal dystrophy, there is some contention regarding this. Either ways, it is not the correct answer because this is the image. And what is the correct answer? What is it? What is this thing? There are a few people who have mistaken this for ACIOL, that is anterior chamber IOL. No, guys, the anterior chamber IOL needs to have haptics also, isn't it? If you have mistaken this for the optic, then do you remember the IOL, that is intraocular lens, the artificial intraocular lens that is implanted after cataract surgery? It has this optic. Optic is the area that acts as the refractive material, and it is held in position with the help of these haptics. This is held in position with the help of these haptics. So here there is no haptic involved. This is not, because this is not a transverse image. This is just an AP image. This is not a lateral view that we can see through the slit lamp. So the people have got confused with ACIOL, but this is not ACIOL. The ACIOL has holes also here. It is not the ACIOL, rather it is intacs. What is intacs? Intracorneal ring segments. Intracorneal ring segments. Okay. Now what do these do? First of all, they are implanted in keratoconus. They are implanted in keratoconus. What is keratoconus? It is ectasia of the cornea. Keratoglobus involves the sclera also. Okay, but keratoconus involves just the cornea. This is the cornea. This is the normal cornea. But in keratoconus, what happens is it has a cone-shaped peak like this, inferiorly, usually inferiorly. Okay, now what happens because of this cone-shaped ectasia or extension of the cornea? What happens is, see, now imagine a balloon. Okay, now the balloon is inflated, say this much. Now someone comes and inflates it more. If the balloon is inflated more, there will be a stretch on the balloon. Okay, there will be a stretch on the balloon. That stretch is going to make the wall of the balloon thinner. That is why this increase in the curvature of the cornea is going to make the cornea thinner. So one pathology in keratoconus that happens is thin cornea, thinning of the cornea. Okay, conical extension, conical peaking occurs. What happens is when this person looks down like this, can you see, if this person looks down like this, then because of the peaking, because of this conical extension or enlargement, what happens is, this is the eyelid, this is the normal cornea. Okay, once this person looks down, then this conical extension of the cornea is going to make the eyelids also become conical like this. Okay, so this conical and conical shape of the eyelid, of the lower eyelid on down gaze is what is known as the Munson's sign. Munson's sign. Okay. Another important thing is the oil droplet reflex. The oil droplet reflex is also present here. Another important sign is the Vogue striae, the vertical striae present in the Descemet's membrane because of stretching. So many things we have learned about keratoconus. Okay. Now, what are the treatment measures of keratoconus? This also we can know. Keratoconus, we have to make this, we have to patch the cornea. Okay. Now, if the balloon, imagine the balloon. If the balloon has been stretched so much, what do? You have to patch that tissue which is stretched, which is thinned out. How do you patch it? You can what can you do for patching? You can apply some chemicals, okay, like M-Seal and all you can apply, right? Those chemicals. So that M-Seal kind of chemical is what? That is C3R. Okay, here you apply some chemicals that will increase the corneal strength. It is C3R or corneal cross-linking. This is one method. Another method is you apply some instruments, or sorry, you apply some small structures that are going to increase the strength there. Okay, some physical material you apply, not chemical, rather some physical material. And that physical material that is going to increase the strength, that is known as intacs or intracorneal ring segments. Inside the cornea, you apply these ring segments that are going to increase the strength of the cornea. Okay. Next, if all else fails, then you have to do penetrating keratoplasty. Okay, got it? Penetrating keratoplasty means corneal transplant. Got it? Understood? So this was about this. Next is a patient presents with mental retardation, inability to get out of bed, and cherry red spot. What is the diagnosis? Now, cherry red spot, I think every one of you knows this mnemonic. Okay, cherry trees. Even I don't usually remember this mnemonic because this is very old. This is even older than when I was taking the PG entrance examination. Even my seniors have memorized this mnemonic only. Cherry trees never grow in sand and mud, is it? Never grow tall, right? Never grow tall in sand and mud. I think this is the mnemonic. I don't even remember what it is. So cherry, what was this cherry red spot? This was commotio retinae. Is no, cherry is nothing, I think, right? And trees is trauma. Okay, cherry was CRAO. Yeah, it was CRAO. So you guys, if this had been a live session, you guys would have prompted, because I don't remember it through the mnemonic. I remember it just through just like that. Okay, but what happens is in high pressure situations or in high adrenaline rush situations, you have to know a few tips of a few mnemonics for better recall. Anyway, so this is CRAO, central retinal artery occlusion. Trees is trauma. What is this trauma? Commotio retinae, Berlin's edema that we discussed. Commotion in the retina. Okay, never is Niemann-Pick's disease. Lysosomal storage disease hai ye, hai na? Gross gangliosidosis. Tall is Tay-Sachs disease, another lipid storage disease. Sand is Sandhoff's disease. Mud is, what is mud? Mucopolysaccharidosis, is it? No. Mud is this one, metachromatic leukodystrophy. Yeah, sorry, metachromatic leukodystrophy. Because mucopolysaccharidosis does not involve cherry red spot. It involves corneal opacity, corneal clouding. Now, out of these hunters and hurlers, hurlers involves corneal clouding. Okay, this was just an extra information. Because how will you remember that? Both of these hunters and hurlers are mucopolysaccharidosis, but hunter and watchers and Tay-Sachs, both of these are lysosomal storage diseases. Hunters and hurlers are mucopolysaccharidosis. Now, out of hunters and hurlers, both of these will appear physiologically similar. Just one difference, that is corneal clouding. Corneal clouding is present in hurlers and absent in hunters. How will you remember? A hunter needs to have a very sharp vision. So for sharp vision, his cornea needs to be clear. His cornea needs to be transparent. His cornea needs to be not clouded. So hunters will have a clear cornea. Hurlers will have corneal clouding. Got it? So this was an extra information. Both of these are mucopolysaccharidosis. The correct answer to this is Tay-Sachs. What is this? Tay-Sachs disease. Okay? Because Gaucher's disease does not have cherry red spot. both of these are lysosomal storage diseases. Okay. And Watcher's disease, also one more thing is mental retardation was mentioned. Watcher's disease has glucocerebrosidase deficiency, isn't it? Glucocerebrosidase deficiency, and glucocerebrosidase does not involve does not cause mental retardation. Okay, understood this? So this was an amalgamation of biochemistry with ophthalmology. Now next question. A diabetic patient presents with pre-retinal hemorrhages and neovascularization at the disc. What is the treatment? Now you have seen there is neovascularization. Neovascularization means once you see, you know there is proliferative diabetic retinopathy. Now ETDRS staging, that is ETDRS staging that we read, you need not remember the whole of the staging. You should just remember that it divides it into non-proliferative disease. It divides diabetic retinopathy into non-proliferative disease with very mild, moderate, severe. Okay, and then very severe is borderline with proliferative diabetic retinopathy. Now, what differentiates proliferative diabetic retinopathy from non-proliferative diabetic retinopathy? Here in proliferative diabetic retinopathy, any fundal lesion with neovascularization, not just fundal, any ocular lesion with neovascularization, if you have, it will come in proliferative diabetic retinopathy. Okay, understood? If you have neovascularization, that means the ischemia has been so prolonged, the ischemia has been so severe that it has led to the ischemia, and the hypoxia has been so much that it has led to development of small vessels. Why does it happen? See, what happens here in diabetic retinopathy is there is microangiopathy. Okay, microangiopathy. The small vessels, the endothelium of the small vessels and the capillaries, they get affected, leading to leakage of blood and formation of hemorrhages, small hemorrhages, deposition of exudates, that is hard exudates. What are these hard exudates? They are lipid deposits, hard exudates, okay, in the outer plexiform layer. So these hemorrhages, hard exudates, they will be present in the non-proliferative disease. But once this microangiopathy continues, there is further insult to the retina and there is ischemia or hypoxia. Okay, now once hypoxia has set in, the demand for oxygen by the retinal tissues has increased a lot. Why? Because of ischemia, the oxygen reaching the retinal tissues has decreased. So they will have less oxygen present. Less oxygen means they have hypox, lesser concentration of oxygen. If they have a lesser concentration of oxygen reaching through the blood, then their demand for oxygen will increase. Now, how will that demand be met? By formation of more blood vessels. Okay, what will the body do? The body will start forming more blood vessels so that more oxygen is delivered to it. But these vessels are baby vessels. They are so small. They have to first form, they have to then get bigger, and then they have to be nourished. Now suppose what happens is a bird has laid eggs, and those eggs, now those eggs have hatched onto small hatchlings, small chicks. Okay, now those small chicks, they will first have to develop feathers, then they will learn flying, and then they will start flying. Okay, now suppose what happens is the bird has laid eggs and the chicks, they have just hatched, and there comes a storm. So the bird forces them to fly away from that tree to escape the storm. Now that storm is what? That storm is hypoxia. Okay, and the chicks, the small baby birds are what? The small vessels that have just formed. Okay, so and what is the bird? Bird is our body. Now our body wants the chicks or the small blood vessels which have just formed to provide more oxygen, to start behaving like big birds, start flying, to escape the storm of hypoxia. But those small vessels cannot do that. Okay, so what happens is these small vessels, they start leaking. They start leaking. The extra blood that is flowing through them, just to quench the hypoxia, they cannot contain that extra blood because their walls are very thin. So they start leaking. Therefore, neovascularization is going to do more harm than good. Okay, so the body, to prevent ischemia, starts forming more blood vessels, and that is neovascularization. These are leaky, thin-walled vessels. Is going to worsen the hemorrhage. Okay, a lot of blood is going to form. It is going to lead to vitreous hemorrhage, pre-retinal hemorrhages, intraretinal hemorrhages. Okay, and the vicious cycle will then continue. So what do we have to do? We have to prevent this neovascularization. We have to treat this neovascularization. There are two ways. One is through anti-VEGF agents, vascular endothelial growth factors. These anti-VEGF agents will prevent the growth of new vessels. Okay, and through laser, you burn these new vessels. Okay, if you burn these new vessels, then they're going to die. Got it? So you have to prevent neovascularization. Have you understood this? Have you understood this whole concept of neovascularization? How is it going to cause harm? Neovascularization develops as a preventive mechanism to cater, to prevent hypoxia, to prevent the ill effects of hypoxia, so that the body, because the body is shouting for oxygen, it is weeping for oxygen, crying for oxygen. So neovascularization develops thin walled vessels so that these vessels will provide more oxygen, but they are not equipped, they're not developed enough. So they will start dying, they will start leaking. Now more hemorrhage will occur, more hypoxia will occur. Then again neovascularization will occur and the vicious cycle will continue. So we have to break this vicious cycle. To break the vicious cycle, we have to prevent neovascularization. That is prevented by either chemical agents, that is anti-VEGF agents, or through laser photocoagulation. The most effective way is excuse me, through laser photocoagulation. Okay, because there are extensive pre-retinal hemorrhages, can you see, and neovascularization at the disc. Now, grid laser photocoagulation, focal laser photocoagulation is for small areas. Here you have to do pan-retinal photocoagulation. Around 2,000 to 3,000 laser spots you have to give. Okay, 2,000 to 3,000 in sittings. Pan-retinal photocoagulation usually occurs in 2 to 3 sittings. Okay, sometimes 4. Alright, scleral buckling, what is it used for? Scleral buckling, it is a treatment for retinal detachment. Retinal detachment also occurs in diabetics. What type? Most commonly is the tractional retinal detachment in diabetics. Okay, so scleral buckling usually occurs when the retinal tear is not at more than at different levels. Okay, because if it is at different levels, then so many buckles you cannot apply. Okay, and when the different tears, the source of the hole and the tears you can see. Okay, if it is not visualizing, if it is not visible to the eye, then you have to go inside the eye and you have to do another type of surgery, that is vitreoretinal surgery. Vitreoretinal surgery for retinal detachment. That is another topic, we can discuss it in some other session. So got it, this one? Next question. I think this one is the last question. A patient presents with photophobia, tearing and headache. Which of the following nerves is involved? A. Optic, B. Oculomotor, C. Trigeminal, or D. Facial. Now, if you look at these symptoms, this one I think is very easy. This is mostly a physiology का question. CNS when you read, mostly a physiology वाला question यार. Ophtha का, I don't think this is a pure Ophtha question. So I'm sure all of you intelligent students would have attempted it and marked it correctly, unless if there was some confusion in the examination hall. Anyway, so photophobia. Now you remember the 5 important symptoms of corneal involvement in any disease that I told you. 5 symptoms of corneal involvement. Can you remember what are the 5 symptoms of corneal involvement in any pathology? What are these? First is lacrimation. Okay. Second is circumcorneal congestion. Lacrimation means tearing. That is increased, that is epiphora, okay, increased watering from the eye. Circumcorneal congestion means this is the cornea. This is the circumcorneal congestion, like this, around the cornea, radially. Okay, involving the limbus also. Then third one is pain, extremely painful. Corneal involvement is extremely painful. Fourth, photophobia. That is inability to look at light. Okay. And fifth one is, of course, because cornea is the main refractory surface of the eye, so blurring of vision. Please remember all these 5 symptoms of corneal involvement, and you tell me this is photophobia, this is tearing. Both of these are occurring in this patient. So some nerve that is supplying the cornea is getting involved. Now, what is one nerve whose sensory supply who carries the sensory stimulus from the cornea? The corneal reflex test tests which nerve, the sensory root of which nerve? The trigeminal nerve, isn't it? The trigeminal nerve. Okay. And this trigeminal nerve, guys, it has 3 divisions, 3 branches. The first one is the ophthalmic division. It is a mixed nerve, right? It has both sensory and motor roots. Yeah. Ophthalmic, maxillary, and mandibular. These are the 3 divisions. Now, this ophthalmic division, this is what supplies the corneal sensations, okay? And this is tested through the corneal reflex, okay? Now, this is what is leading to photophobia and tearing. And the headache is because of trigeminal neuralgia. Trigeminal neuralgia. Haven't you heard of it? The trigeminal nerve near the temple, the ophthalmic division only, near the temple, once it gets inflamed, it leads to throbbing, very tearing type of headache, so much so that the person is unable to open his eyes. The eyes keep on watering all the time. The person is unable to chew food. So it is such a debilitating headache. The famous actor Salman Khan had suffered from this trigeminal neuralgia. That was in news, okay, a few years ago. So it is an inflammatory condition involving the trigeminal nerve, where the pain becomes so debilitating that the person cannot even talk. The normal talking also stimulates the nerve so much that it starts paining a lot. So that is trigeminal neuralgia, a very painful condition leading to headache. Okay, understood. So this is trigeminal nerve. Why is it not the optic nerve? It is not, because naturally optic nerve is involved in vision. None of this optic nerve does not carry these sensations. It is not involved in this. It is involved in vision. Optic nerve tests. What are these? The tests for optic nerve: visual acuity, color vision, contrast testing. All these are tests for optic nerve. Okay, visual acuity, color vision, and contrast testing. Okay. Now, oculomotor nerve supplies what? Most of the extraocular muscles except LR6 and SO4. LR6 and SO4. LR6 is lateral rectus by abducens, SO4 by trochlear superior oblique. So oculomotor supplies the rest of the extraocular muscles. Facial nerve. So that is also not involved. None of these symptoms caters to that. Facial nerve. Now, tearing can be associated with facial nerve paralysis, but there is no mention of legophthalmos. There is no mention of drooping of the face or asymmetry of the face. Okay, so mostly, or if you club all the symptoms, then the one nerve that will satisfy the involvement of all these symptoms is trigemine. Okay, got it? So I hope you guys have benefited from this discussion.